start. I hope I'm audible to everyone. Thank you everyone for joining in this webinar on scleral fixated IOLs. We have a very exciting lineup of speakers and panelists who are absolute experts in this field and who've joined us from different places and will be teaching all of us. I'll just take 5 minutes in the starting to introduce everyone. We have Dr. Ritesh Narula. So Dr. Narula is from LV Prasad Eye Institute. I've had the good fortune of learning the glued IOL technique from him. Wow. Watching him operate is like seeing an absolute artist do this surgery. Thank you for being here, sir, and we look forward to your talks. We have Dr. Ephraim Mandelkorn. Dr. Mandelkorn is a professor of the Department of Ophthalmology in the University of Toronto. And he's the ophthalmologist in chief and director of Retina Services and the Retina Fellowship Program of the University Health Network. And he's trained from the top schools, right from the University of Toronto to the Bascom Palmer Eye Institute, and has won multiple awards for teaching. It's an absolute honor to have you here, sir. We have Dr. M. Nivian, who's the director of academics at the MN Eye Institute. He is already very well-known retina and cataract surgeons, and like we know, retina surgeons do the best IOL surgeries. He'll be talking to us about the CMT Flex IOL. Talking about the CMT Flex IOL, we have Dr. Agostino Vaiano. So Dr. Vaiano is the head of ophthalmology at the Santa Croce and Carle Hospital in Cuneo, Italy. And in fact, this is his second meeting of the day on this topic. He's in Bari right now at the Retin Bari conference, where he's already taught surgeons there about the Carleval IOL, and he's joining us now. The very fact that he's in two different meetings in two different parts of the world on the same topic shows his expertise on the subject. And for those of you who don't know, the Carleval IOL is the IOL on the platform on which the CMT Flex is based. And if you look at Dr. Vaiano's body of work, there's a lot of data on the long-term outcomes, even EDOF, CMT, Carleval lenses, and even the aniridia lenses. So we look forward to learning from you, Dr. Vaiano. Thank you for joining us today, despite having a busy schedule. We have Dr. Ahmed Mansoor from Egypt, from the Ain Shams University. He's a very dynamic, high-volume vitreoretinal surgeon. In my interaction with him, I realized that he has a very clear way of thinking and will get his point across in the simplest way possible. And he's going to talk to us about the Canabrava IOL fixation, and he's going to teach us about it. Thank you, Dr. Mansoor, for being here in the middle of your day, and we look forward to learning from you. And we have Dr. Ashray Nayak. Dr. Ashray Nayak is an alumnus of LV Prasad Eye Institute and works at the Eye Foundation in Coimbatore. We all know him as a surgeon and retina surgeon, but he's also an innovator, and he'll be talking to us about his innovation on the implantable capsular bag, which will maybe be out there in the future and change how we perform scleral fixation. I thank all of you for being here, and I thank all the attendees who've joined in today. We also have with us our panelists. We have Dr. Vishal Agarwal, who is from the Governing Council of the VRSI. He's from RP Center, and a lot of people who have trained at AIMS and learned retina at AIMS have learned from him. It's an absolute honor to have you, sir, and we hope to learn from your expertise as always. We have Dr. Okay, the screen has been shared. And we also have our ASG panelists, Dr. Kaushik Tripathi, Dr. Atul Dhawan, Dr. Ganesh Pillai, who are in the academic cell and responsible. Nice to have Karthikeya Singh, who's the Yosi Retina lead, and Dr. Anubhav Upadhyay, who are young, high-volume surgeons in the ASG network, and we'll love your inputs as well. And we also have Dr. Vikas Ambia, who's also an alumnus of AFMC and LV Prasad Eye Institute. He's a professor of ophthalmology at the Armed Forces Medical College and handles a very high-volume retina practice there. It's nice of you to be here, sir. Thank you for being here. So without much ado and without wasting more time, we'll start with the first talk by Ritesh. If you could please share your screen, sir, and we can start with the talk. Thank you so much for being here.
Thank you, Arjun, for that invitation, and A nice introduction that you gave. I would like to share my screen now.
I just request all the attendees to please mute yourself so that there are no interruptions during the talk.
Is my screen visible?
Yes, sir, it's visible. And you're audible as well.
So, am I on the full screen and can I go ahead?
Yeah, you can go ahead. You are on the full screen.
Sure. Thank you. Uh, at the outset, very good evening to all of you, and thank you, Dr. Arjun, for this invitation and the AG Network for such an interesting webinar. This is something which is very relevant, not just to only the retina specialists, but anybody who is doing IOL, handling difficult, complex situations. This webinar, I think, would be a lot valuable to all. Arjun told me to focus my talk typically on how I do glued IOL and the nuances and tips that I can share. So I'll do that with a very brief introduction. My talk would basically be talking about the technique, the indications, some of the complications, and what our experience in terms of data has shown how it has done for us. So we know we need all these issues when you have an posterior capsular absence and you need to fix an IOL in those situations. Multiple options like an RS fixated AC IOL and obviously the transscleral fixation of IOL, whether with sutures or haptic externalization, which we typically call it as glued IOL, are the options. And since about 2012 onwards, I started moving away from the sutured scleral fixated IOL, which I was earlier doing. And reason being, the amount of expertise required there, the learning curve was much more for anybody coming forth, and the longer surgical time it took to do a sutured SFIOL, and then add to it a few complications like suture-induced inflammation. Over time, the suture degrades, breaks, and then you can have a delayed onset subluxation dislocation, which made me slowly push my uh, kind of graph more towards the glued IOL technique. So there are three basic components. The technique that I'm going to be talking about is a modification which you call as the Agarwal modification of the standard Gabor-Sharier technique of glued IOL. I have persisted with this technique after going through multiple other iterations of this haptic externalization technique. Uh, Basically because it allowed me a lot of flexibility to handle a lot of complex scenario of other than just a basic glued IOL surgery. And also, slowly over a period of time, it started moving for me from just fixing an IOL in the sulcus to getting that refractive neutrality and being able to hit more and more with the 6/6 N6 vision, along with minimum astigmatism, minimum manipulation, and safest onto the anterior segment. So all this led me to master this technique, and then somehow I've just persisted with it. I'm pretty happy with the outcomes. So three basic components of any glued IOL surgery: a three-piece foldable intraocular lens, can be a non-foldable. Also now we have some options there. A surgical technique involving haptic externalization and the fibrin glue. Coming to IOLs, you have two kind of IOLs. There's no financial disclosures here: a J loop haptic and a C loop haptic design. All of them are both these are actually hydrophobic foldable lenses with a PMMA haptic. The J loop works better in my hand because it allows me a little larger amount of haptic out of the eye for a better tuck in these situations compared to C loop, which has a tendency to kind of slip back if there is a slight decentration there. So that's how I fixed somehow to the J loop haptic design. Works well in my hand. A fibrin glue typically consists of two components, a human fibrinogen and a human thrombin. When mixed together using either a mixing chamber or a single plunger or two different syringes on a dry surface, forms a nice fibrin coagulum there, holds the sclera, the conjunctiva, and the haptic hence would tuck in its place. Is it a 100% necessity? No, can be replaced by a suture. It's more of keeping this surgery as sutureless as possible and keeping a clean, quiet surface there. So going on with my technique of glued IOL, typically starts off with marking the 3 and 9 o'clock meridian. Or any other meridian. The flexibility herein is if I find a particular meridian has a smaller cord length, I would shift to that meridian. I can say temporal, supratemporal. If a patient has had previous squint surgeries, the conjunctiva is scarred, or there is a trauma, I can move my position as per my requirement. So mark the two 180-degree axis. Very particular about this because, as I said, I'm aiming for a astigmatic neutrality. So my measurements, I'm pretty particular about getting 180-degree kind of apart and having equidistance haptic externalization is something I really focus on. Step two, a good conjunctival peritomy. I typically do a L-shaped peritomy. Cleanly cuts, gives me wide enough exposure, and later on you'll realize a single flap gets it back into its position, nicely cover the scleral flaps. One of the complications is of this surgery is you can have flap exposure. So you don't want very short conjunctival openings which are not nicely covered, nicely covering the scleral flaps. So keeping that in mind, this kind of a L-shaped flap, cauterize the bed, and then move ahead with my scleral flaps. So again, you'll realize herein these are 3 mm by roughly about 3 by 3 mm scleral flaps using a crescent knife here. When I make these flaps, I typically make sure I do not handle the time. So once my flaps are done, this is a slight modification which I do. I've secured the infusion. Now I make my openings for vitrectomy right under the flap. The point of insertion here is roughly about 1.9 to 2 mm behind the limbus, under the flap, 180 again apart, equidistance on both sides. And I use these ports itself for vitrectomy, and subsequently these ports will also be used for haptic externalization, avoiding any extra ports for me. It's a little tricky initially because you're at 180, the the nose comes into place, but with practice, I have kind of mastered this art of keeping my ports under the flap and avoiding any extra uh, ports there in the sclera. Step next, vitrectomy is where you use an injector with your lens folded in, and you inject this IOL inside the eye, get the tip just out. Do not inject it too much, it makes the IOL quite mobile. The tip of the forceps is used to handle the tip of the IOL. I'll take my time there till I get the tip nicely, inject the IOL in the anterior chamber. Once it's completely inside and unfolding nicely, after that only I start withdrawing the haptic out. Doing too much at the same time, doing multiple steps at the same time may actually damage the haptic optic junction. So smoothly getting the haptic out, transferring it to the other hand, and then letting the other haptic slide in. Herein, I've used a scleral tunnel. You can do the same thing with a clear corneal tunnel also. Uh, Whether I'm doing a scleral tunnel or a clear corneal, still prefer an injector, keeps the globe more tight and stable. Once one haptic is out, I just turn the IOL a little vertical, which allows, you'll realize it allows the other haptic to face me practically. And I can just go and handle the tip. I do not need any assistant to help me out there. Just handle the tip, turn it back horizontal and get the other haptic out. Once the haptics are out, the main wound is secured, is where you make those Gabor Sharia tunnels. A 26 gauge needle is used. Looking at the position of the haptic, I would, in the same line of the plane, I would make my grooves there and tuck the haptic equidistance on either side. So doing it on the one side and then subsequently the same process repeated on the other side. Carefully again noting, look at the position of your haptic, how much it has to be tucked in so that you do not over pull it on one side then or under on the other side. And generally being maintaining the direction in which the haptic has to go. So again, tucking it nicely. And then once this is done, practically done with the surgery, you take your fibrin glue, switch off the infusion, dry the bed nicely with a Merusol sponge, and then you can put both the components of your fibrin glue, the thick and the thick. Before I do that, I always clean up the conjunctiva, ensure there are no clots, holding back the speculum also to allow for the conjunctiva to kind of easily come in front to cover the flap. Put the thick component, put the thin component, put the flap in place, cover it with conjunctiva, nicely massage it, and that's it. Done. So do it to all the three parts, and you're practically done with your surgery. Yes, close it, no suture required, the job done. So this Gabor chariot tunnels are very useful for me because it just puts the haptic in its place. Once it is in its place, there is no forward backward movements. There's no phacodonesis that you'll ever see in these IOLs, and keeps the IOL pretty secure. Advantages, as I said, decreased phacodonesis, better centration of IOL, no tilt is what I feel are the advantages of this technique. And obviously the other complications which are there with sutured SFIOL I've already talked about, which are not there here. So indications can be variety of indications, whether traumatic, atraumatic, congenital, and we have tried in all of these situations different this glued IOL technique. The flexibilities, I'll show you some flexibilities of this technique. This is one of my older videos. Again, if you are worried that, as you sometimes the patient, I've heard of people complaining that these ports which you make may leak or they may bleed. So herein, if you will realize, I have started using these ports itself. So when you take out this forceps haptic, just slide the trocar over it and then nicely, just gently take it out. Keeps the wound very tight in its position. So that's one of the modifications. You can combine it with other procedures. This was one which I combined it with kind of a, a lensectomy. When we went in, after doing the lensectomy, realized there is a vitreous hemorrhage, completed the vitrectomy of the vitreous hemorrhage, removed the lens matter. There was a macular hole. So decided to go ahead and peel the ILM, created an ILM flap, then covered the flap over it, completed the glued IOL and finished it with. I had to make extra ports here to complete my fluid gas exchange, and but was able to complete it and had a good closure at the end. You can fix even a dropped three-piece IOL. You do not start looking for a new IOL. If it's dropped inside, you conventionally make your flaps, your entries, and you can use chandelier if you really want to have a nice control over it. But herein you see a haptic bend. I'll talk about it in my next video. I'll show you why it happens. But you can practically fixate the same IOL back into its position. So sharing my experience here, we did our first analysis about 2020, about 1,000 eyes that we had done, and with various indications and the success rate. We had a mean follow-up period of 6 months. We saw all of them. We had a great post-op visual acuity. 78% patients had vision better than 20/40. For others, we had complications such as optic atrophy, macular edema, vitreous hemorrhage scars, and we even did it with post-keratoplasty, post-DSEC, combined this procedure with DSEC also. Just showing few cases here, a patient of Marfan's, the pre and the post-op. One anteriorly placed three-piece, the same IOL kind of pushed back and taken haptic externalized and used. Patient with trauma, patient again doing pretty well. Complications, we had our fair share of complications, the initial learning curve, more so when we are doing the surgeries initially, but there were a fair share of them, most common being post-operative CME. We had quite a few haptic bend and break on externalization during our early learning curve, just thankfully has come down now. Why it happens? You should see here. It happens because if you're holding this haptic instead of at its tip, somewhere more away from the tip and more instead of being in line with the haptic perpendicular to it, when you're going to take it out, the haptic optic junction, wherever you're holding the haptic will bend there. So you have to hold it flat and straight in line with the forceps and the haptic preferably in line. Another complication, scleral flap melt. We had two patients, the conjunctiva retracted, the flap practically melt, and eventually we had to do a patch graft in these eyes. We also looked at our outcomes of retinal detachment in these cases, and we analyzed what was the cause which was happening. We had about 1.8% of patients out of the 26,600 eyes we analyzed somewhere in 2022. So 50 eyes had detachment, and some of the learnings from this particular paper was the incidence was slightly higher than a typical pseudophakicardia, understandably because they are more complicated surgeries, had a lot of other complications. In patients of history of trauma and patients with ectopia lens and lentis turned out to be one of the risk factors. Marfan's patient had a higher incidence. And any patient which required a second procedure, as whether it was conjunctival retraction being repaired and having exposure taken care of, all of them slightly higher risk of retinal detachment. And most of these happened within the first 3 months of glued procedure. So with this, I would like to conclude a technique which has really worked well for me over the last decade. And the surgical time has gone down, the successes has improved. The learning curve is there, but I think it's something which is easy to adopt and can be mastered over a period of time. Thank you.
Thank you for that amazing presentation. And you made that technique look so effortless, and you brought about very nice points, especially how the versatility of the technique is to combine it with different procedures. I'd just like to move over to our other panelists and speakers and audience for any questions they have.
Good evening, Dr. Ritesh, and very nice presentation.
Thank you.
I'd just like to ask one question. How much vitrectomy do you do in the case of blue dial? If the patient is coming with the full vitreous, how much vitrectomy you do?
I am a vitreoretinal surgeon. I don't like leaving behind vitreous. I'll put it like that. So glued IOL means complete vitrectomy. I take the vitreous completely out. Maybe not do a base shave, but otherwise, other than that, I do not leave behind vitreous.
I
So
had
in
a
all the
question where
cases
you
you
combined. No, sir, please go
so
ahead.
in all the cases so in all the cases you do the PVD induction.
Yes, in all the cases, if I'm doing a glued IOL, the PVD induction is done and the vitreous is completely removed.
Okay.
I had a question
Thank
where
you.
you combined the glued IOL procedure with the macular hole surgery. Would the gas bubble ever cause the lens to tilt if it's a superior bubble? Does that ever happen?
That is something wherein the tucking of the haptic really works well because the haptics are so tightly tucked in that the IOL doesn't tilt. We have seen this happening with iris claws, where I've seen iris claw literally becoming vertical because the whole thing twists on its axis. But with this technique, where a lot of haptic is out and secured into the scleral tunnels, it doesn't happen. The IOL doesn't tilt.
So I just to answer that,
Yeah.
excellent presentation, Ritesh. So he's right that it does not tilt under gas, under air, and in iris fixated there is a tilt, and the air might come into the AC. It does not tilt even in Yamane. So these are very stable IOLs. I generally prefer nowadays iris fixated or Yamane. I do these glued IOLs in cases of internal fixation of the IOLs if the three piece is dislocated, or even PMMA for that matter. So they do very nicely. You don't have to extrudize the IOL, and you can refixate it internally by making those tunnels. So very elegant technique described.
Thank you, Ishan. I
Thank you.
agree with what you
Hello,
said.
good
We'll
evening,
just move on
Dr.
to the
Ritesh. Sir,
next.
yeah, please. I
Please
just
go
want
ahead,
to
Dr.
ask one thing. Yes, excellent presentation, Dr. Ritesh. Sir, I want to ask that I practice myself also Gabor Shariat technique, and I feel difficulty in cases, especially in those having thin sclera or the white to white ratio is like cornea is big horizontally. So in such cases, do you change your technique or do Yamane, or what is your trick in those cases?
So in cases, so this is my preferred technique for most of the surgical aphakias. If the white to white is large, or if the sclera is extremely thin. If the sclera is thin, then other forms of scleral fixation, whether it is sutures or Yamane, is something which I'll avoid there also. There I would do an iris claw, which is my second preferred technique now. Uh, and in cases where white to white is large and sclera is reasonably okay, I can opt for, I do sutured SFIOLs in those cases also. But in those cases, there's no modification of glued IOL I'll advise. I generally don't do it myself. I don't advise glued IOL in those cases where white to whites are too large. I generally avoid doing it in those cases. I'd either do an iris claw or a sutured SFIOL, depending on the
Yes, sir.
sclera.
So one more thing is there in the limitation of Gabor Shariat, what I feel is that it's not applicable in all kind of IOLs. For example, if it is a sensor three piece, then if the haptic length is small, then there is a limitation of tunnel because you have to insert a certain length inside the tunnel so that the IOL stability is there.
Yes.
So you do it, but all IOLs apart from the ones you mentioned, you prefer that you use such technique, because myself I feel that Aerofold three piece is also as equally good as Alcon and other IOL you mentioned.
Correct. So I have used, my preferred is Alcon MS60 J loop haptics, but apart from that, Orofold three piece works. I've even used Oro PMMA three piece also, which works pretty well. Stensa, the haptics are small, as you rightly mentioned, and somehow the haptic optic junction is quite rigid and breaks on slight manipulation. Technis three piece, I have used a Technis three piece works fine, but not as, because of the C loop, I prefer the J loop haptic generally, so I use an Alcon MS60. Gives me a little larger
Yes, sir.
length.
And so the creation of the flap, does it give an extra advantage? Because I don't make flap, I just insert take out the haptic and then insert in the Gabor Sharia tunnel. So creation of a flap does give an extra advantage for the IOL stability. What do you feel?
I feel because I'm not making any other additional ports for doing vitrectomy, it covers my vitrectomy ports also nicely, and also my haptic. I don't have any haptic edge or a bend or a junction which is kind of exposed under the conjunctiva. And I don't have any other ports which I need to suture or take care of. Everything is under the flap, under the conjunctiva.
Yes, sir. And if 3 and 9 o'clock are scarred because of previous surgeries, then how will we manage in those cases?
I sit temporal, supratemporal, supranasal. Any two 180-degree apart meridian I should get, which are the conjunctiva is good. I am okay to. Other than sitting on the patient's chest, I think I may have practically moved all around, all around the
Yes.
place.
Thank you. Thank you
So
so much, sir. Brilliantly presented. Thank you so much.
thank you.
Thank you so much, Ritesh sir.
So very nice,
I'll now
very nice talk, Dr. Ritesh. Can I just ask one question?
Sure, sure.
How often do you do laser in cases of ectopia lentis and all those cases which you mentioned? The chances of RD is higher. So where do you do 360-degree barrage in these cases routinely?
No, I
Or
do not do prophylactic barrage in these eyes. Um, I, if there is any hole tear, only in those situations I would be doing, but otherwise I do not do prophylactic barrage.
okay.
Arjun, can I make a point?
so yeah, please go ahead.
Actually, Dr. Anubhav just wanted to throw some light on the 2007 JCRS Shariat Gabbar's paper. In fact, he just exteriorized the haptics from the sclerotomy and put it directly under the conjunctiva. It is Dr. Amar
Yes.
Agarwal who made that flaps. So in case where the
Yes.
sclera is thin, or majority of the cases, you don't have to make it. If you are able to cover the conjunctiva really well, it is good enough. But in the original paper, it was not there. Since this exteriorization, if sir told about the Shariat's tunnel, if you don't tuck it properly, then you will unnecessarily will have exposure and it will poke out from the conjunctiva. So and if
Yes,
it
sir.
is
Yes.
more than 14 so the another modification is you can go through the iris itself, because the overall diameter is only 13 If you don't go through the iris, then the part which needs to be tucked will be very less, so it can get internalized.
Exactly.
So there
Exactly.
you can in those are special situations, there you can go through the iris itself.
Yes, sir. In those cases, sir, I do Yamane because somehow
Yeah, yeah.
going through that area and becomes a bit complicated. So
No, that's what in Yamane, if you look at his original paper, Yamane, only very few cases he used these haptics. So we also feel that that blue color haptics are not Prolene haptics, or this thing. Those are PMMA haptics. When you put a
exactly.
heat cautery, they should make a blob which is more than the sclerotomy. So there, what it has, they measured about 1.14 of blob. Here with PMMA, with such a smaller haptic diameter, you will find it difficult, or it can have an
Difficult.
internalization. So there he used in his original paper, majority of the papers were PVDF haptics, where the
Yes, yes, yes,
blob can become much more.
yes.
Sure. So that was a very nice discussion. We have three more questions for Ritesh sir, which you could please take up in the chat box from Dr. Amit Nene, Dr. Saurabh Gupta, and Dr. Aviral Vasudev. Also, three questions which were asked, which are sort of common for all techniques where there is some discrepancy. One, extent of vitrectomy, and two, what do you do when there is a problem at the 3 and 9, which are a typical sites of externalization? And third, in cases like ectopia lentis or cases like that, what is your take on laser? I would like to ask these questions to all our speakers and Dr. Vayano once the talks are done, and we can have these in our discussion as well. And now, without wasting much time, I'd like to call upon Dr. Ephraim Mandelkorn. So, Dr. Mandelkorn will be talking to us about his way of doing the Yamane technique. And I'd also like to request all our participants to just make sure they're muted in between so that there are no disturbances. Dr. Mandelkorn, you can please share your screen. Thank you for being here. Dr. Mandelkorn has joined us from Canada. It's the morning for him and middle of a working day, and he's very kindly agreed to be here. Thank you so much for being here.
Great. I'm trying to share. Thank you, Arjun. I appreciate you inviting me. Is it shared my window?
Yeah, it is loading. Not visible yet.
Back to the window. Do you see it now, or do you see it or not yet?
No, it's not visible yet to me.
Stop sharing.
Yes, we see it.
You see it? Is it full screen for you? Or not?
Yes.
You see my slide? Yes?
Yes, Dr. Mandelkorn. It's
okay,
visible.
good. Okay. Thank you, everyone. Thanks for having me, Arjun, and I appreciate the invitation. We met at a meeting in the US, so I appreciate being invited. I'm going to talk about the Yamane technique, scleral fixated IOL. Maybe someone can mute their microphone there. It's a lot of feedback. Maybe it's just my computer. Whoever is making the noise. Thank you. So I'm going to talk about the IOL fixation. Just briefly, as we all know, there are risk factors for subluxation of implants and certain risk factors which have been discussed in the previous talk. And there are these result in different symptoms: diplopia, blurred vision, or glare, etc. There's many approaches, as we're seeing, and I'm sure the talks will be all very interesting. I'm here to talk about the bottom one, which is the Yamane scleral fixation of IOL. So the original paper looked at this technique and found very good results. So I'm just going to go right to my video to show you how I do it. And I'll pause every so often. So usually what I do here, first of all, is I mark the eye. I used to use a marker, and now I eyeball it, holding the eye stable, and usually come from the center to mark the center of the cornea, from the center of the cornea outwards. The next thing I do for modification here is I will block, but I use an angiocath, which I'm going to show you afterwards. And the angiocath has a benefit of, it allows me to top up the eye with further block, as opposed to a cut down with a blunt cannula, which usually what I normally do is a subtenon in most cases. Here I'm using the angiocath, and I place that in a peribulbar kind of fashion infranasally, and then I will place the
Please mute yourselves.
I will place the block through this cannula here. And that basically, the benefit of this, doing it this way, is you avoid chemosis and hemorrhage, which I think really improves your visualization for most of these techniques. I'm not sure what the panel does with regards to block, but unless you do a sharp block before. But if I block, you're normally in a cut down, you create some chemosis. The second thing is the placement of my trocars is deliberately placed in a more superior and inferior location, as you see here. I leave a large space temporally and nasally for the Yamani fixation, and that allows my haptics to have more space for the cautery. So I place the 3 trocars in the usual fashion for vitrectomy. This is a patient who had a drop cataract, and there's the piece of cataract on the retinal surface. So this is just standard initial part of the procedure. There is a rupture in the capsule. It's basically the capsule is compromised. This is the angiocath I was mentioning, and I use this for the block, as I mentioned earlier, but the other portion of this which I use is the tip of it. I use both parts. I don't want to waste any part of instrumentation, of course, because of budgets here in Canada. So I use the cap here, and I take this cap and I place it on the top of the TSK thin wall needle, which I use for my scleral tunnels. And the benefit of that is that I'm able to place the needle and have no leakage. So the eye remains in a stable fashion during the Yamani. That way I place the needle. So here I bend my needles with a what's it called, a needle driver, and then I actually check the angle of my needles to make sure that they're both relatively equal with regards to angle, and that I think helps ensure that the angle of my pass of my needle is in the same orientation and degree. Once I've verified they're about the same, I then 2.5 millimeter caliper, and I place the needle in about a 15 degree or so angle through the sclera. Try to keep it even on both sides. This is obviously a very crucial step, as you all know, and do the same thing on the temporal side. And because my trocars are out of the way, I have a lot of space to do this without having to worry about bumping into the trocar. And what you'll notice after this is passed is that the caps of the needles allow me to leave the needle in place and not actually hold anything. If this is attached to a syringe, it's very bulky. And if it's attached to no cap, which is the cap I was mentioning before from the angiocath, it leaks. And then the eye becomes soft and hypotenuse, and you can run into risk of bleeding or just have an unstable eye, and it's difficult to place some of the instrumentation later. This is another picture externally. You see the caps within the needle tips, and I can just leave it. I know it's in a very good orientation because I passed it with good measurement. So then I place this is an AR40 Sensar IOL, which I find the haptics are the best balance of minimal tilt of the haptic optic junction and also stable, that they don't bend like an MA60 Alcon lens. Oh, sorry, I went too far. My apologies. Hold on. Okay, we're here. So place the IOL in the eye here, and the initial, I find if you streamline this, with how you orient the needles and also how you come in with your forceps, it really is a routine pass. I find this part used to be challenging. This part is no longer challenging, maybe because of experience. But I grab the haptic. Now, the key here when you're grabbing the haptic is you want to grab just distal to the apex of the center of the haptic. If you're too far to the right here, maybe you can see my mouse, then it's too long and it can bend when you place in the needle. And if you're too short, it's hard to tuck it. So I look at the apex of the haptic and I go just less than that, to the left side of that here in this case. And then when you're docking your haptic, I use that as a shelf just to slide it down without bending the tip. Once I've tucked it in, I do small little tucks of the haptic. This part here, because of my placement of my side port on the nasal side, just above the blue dot, I find it's a direct access to the trailing haptic needle. This is often challenging, but if you place your side port here, it's actually not too bad. It's directly across. You see here, I just use the shelf of the needle and just slide it in gently. Go about halfway here. And then I externalize both slightly, but not fully, just to get the implant a little more centered. And here, the key here is that once I'm pulling out the haptic, I grab it and I continue to tuck it back in the eye sequentially. It happens very fast here, but not to pull on the haptic optic junction. So I'm pulling it, I'm gently leading it back into the eye. The infusion is off, so there's no water. I use something to dry it and just do a small bulb. Again, you'll see here I'm tucking it back in as I go. And once it's now just the tip of it is exposed, I will get a Q-tip here. I have no fellow, I'm by myself. I push down to dry, and this is low temp cautery, and I make my bulb and I tuck it in. At the end of the case, I'm going to use myocol to make sure that the optic is covered. There's no vitreous. I have done a complete vitrectomy. I always create an iridectomy. You sometimes will get optic capture. This kind of helps reduce that risk. And once the iridectomy is in place, I do a small air exchange and take out my trocars. So this again is the tip of the angiocath, which I use as a standard angiocath. Most of your anesthetists will use this for the IV. I just take it from them. Again, this is the picture I showed before. So there's always a couple examples where things don't go well. I'm going to show you, share with you my complications. And these are three interesting examples just to share for learning. I'll give you three cases where things didn't go as planned. This is a patient who was actually working at the Children's Hospital, so very anxiety-provoking case. Everything's going well. I'm tucking the haptics as usual. You see the first one comes in, and then as I'm passing the second haptic, the trailing haptic, I noticed that there's some vitreous, a pretty large amount of vitreous. I did a full vitrectomy, but this kind of snuck up on me. Wasn't expecting it, and the vitreous is now noted just at the edge of the haptic. So I stop what I'm doing, and let's see in a second here. And I take my cutter and I try to just disincarcerate that vitreous from the haptic and the needle here. I think I do a reasonably good job here. So I can proceed with the fixation. I bring the haptic out slowly. And you see here, this is older, I'm using the high temp cautery here, which I don't do anymore. Externalize the haptics. And then of course, and this is the question which was asked in the chat, which is, do you do a complete vitrectomy? Well, I thought I did in this case. Actually, the patient had dropped cataract. But this is why you got to be very careful with your vitrectomy. And it lends to the question of, should anterior or middle segment surgeons be doing this? Because this is always a question, right? And I'm sure there are some anterior segment surgeons on the call and we can discuss it. But this is why you got to be very careful. So at the end, I put my myocall and the pupil is peaked. There's correctopia. And I look inside. And of course, there is a very large, giant retinal tear, which was not present prior to the Yamani, going 6 clock hours from 9 o'clock to 3 o'clock. So luckily I'm prepared and I'm looking. And I look carefully at the vitreous base. I shave the vitreous down now all the way to the vitreous base. I place laser. I place C3F8 gas for this giant tear. You can see it here. And the patient has to undergo positioning. This is all unexpected, of course. And of course, because everything was checked, they have a 2025 result 3 months later after a very long recovery. So lesson number one is make sure you do a full vitrectomy and make sure you check your vitreous base. This is another example. This is a young man who was referred actually to Canada. He was a South African man who had trauma, 33 years old, and he was referred with a dislocated IOL, which was sutured in South Africa. And when he came to see me through the emergency department, I thought, okay, well, he's got an iris prosthesis here. You can see this is, I think, the human optics with an iris remnant from the trauma. And I thought, well, okay, I'll somehow figure out how to get out this three-piece implant, which is now on the retinal surface. I'm not sure if it'll come through the pupil. I've never dealt with an iris prosthesis before, really. And I thought maybe I could bring it through the pupil, but I wasn't really sure how I would deal with it. There was some thinning here superiorly, so I had to adjust the placement of my trocars. So I place my trocars now inferiorly and superiorly just because I want to leave space for where I think I'm going to fixate. So as you see the case go on, the minute I put my cutter in, unexpectedly, the iris prosthesis completely dislocated. And I was like, I wasn't expecting this, of course. I didn't realize that was also going to dislocate. So now I had to deal with something a little more complicated. I managed to pick up this implant, which I thought was a little bit small. I wasn't sure what type of implant it was. We don't have this in Canada. And I had to get it through some type of gymnastics through the iris prosthesis. I cut it as usual in a Pac-Man configuration and removed it. And then I had to think, how am I going to do the Yamani? How am I going to get this implant in? I have to probably go around the edge of this prosthesis. It's still on a hinge. So my usual, this way I actually brought this implant in. I did my this is a bit older. I put my needle in late and tried to figure out how to get this haptic to go through the pupil, around the pupil. I was trying to figure out what was going to work. You can see me struggle a little bit. And then I managed to get this with very poor visualization behind the iris prosthesis. And I thought, okay, that was a pretty good win. I was happy with that. And then just dealing with the iris, again, this is not something I do with frequently, but I decided I would place a 5-0 Pro lead and do a double flange. So I place the 5-0 Pro lead through a needle. I externalize it on each end through the iris prosthesis and sclera. And then I make a large bulb with cautery and bring that through and then make a second bulb through the other side. I thought this looked pretty good. I thought maybe I'll do one more because it was still a little bit mobile. So I did a second location for the double flange with a 5-0 Pro lead, and this is a pretty nice result. So iris prosthesis, another thing to consider if you ever have to deal with this. This is the final case. And this is the patient who everything was. This is. Oh, I'm a little bit echoing. This patient had a detachment and was silicone oil. And it was aphakic, and this is at least 10 years ago, 2015, I think. And I'm doing the case. Everything's going great. Silicone oil was removed. Retina is detached. So I'm removing the haptics, looking good. Got some good music playing in the operating room. And then suddenly this happens. Let the music play. You can watch in disbelief. So as you can see, the cautery was a high temp cautery, which I don't use anymore because of this. And the drape caught fire during the burning of the haptic. Luckily, the nurse actually had prepared a combination pack and had a little bin of water, which from the prime, and it was prepared, which was lucky for me and for us. So I sort of didn't know what to do. We were trying to figure out where the fire was coming from. And of course, everyone's getting very anxious in the operating room, as you can probably imagine. Things get a little shaky. And the nurse finds this water. She sort of reacts quickly, grabs this thing of water, and just puts out the fire very, very nicely. And the fire stops. So now I am obviously very shaken up, as I'm sure many of you would be. This is very unexpected and definitely a good learning point for everybody on the time presenting it, because I think it's important to see this. I still have the implant. Haptic is dislocated in the vitreous, so I have to finish the case, even though I'm quite shaken up, and place my needle. Just want to get this case complete and get done. Feed the haptic. Bring out the cautery very cautiously this time. So, I mean, it's a good learning point for everybody here. Just to say that when we do cautery, and we all use it, there are just three main risk factors for fire, intraoperative fire, and they include, some kind of ignition source like a cautery or light or laser, and we have all three in retinal surgery. High oxygen concentration, and we have, a tent of oxygen at high flow going the entire case. It's like a bomb waiting to go off, and then anything above the xiphoid bone. So we're 3 for 3 in ophthalmology with regards to risk. So it's just something to keep in mind. Because of this case, I made modifications to how I do this. This is 11 years ago. I'd never used the high temp. I used the low temp cautery. I turn the oxygen off. We have a timeout actually in the case where oxygen goes off before any cautery is used. And I'm very cautious about having any kind of material near the drape. So I'm bringing this to everyone. Obviously, it's not, we don't have to share our complications, but I feel like it's actually important that everybody is aware of this risk and learn from my experience. So I'll just close with fixation of IOL, fixate with intention and with careful judgment. Thank you.
Thank you for sharing those beautiful cases with us. The cath needle modification was amazing, and the way you handled the complications also seemed so effortless. I don't think any amount of training can prepare you for some of those. I'd just like to hear from Dr. Vayano if he's faced any such situations in his OR ever, in terms of complications while doing scleral fixated lenses.
Thank you for your amazing surgeries. One consideration, I think that is very important to use for Yamane technique IOL with the PVDF loop. It's very important for me because in my experience, PMMA loop can we can manage it. And so PVDF is stronger than the other one. The second is very important to use the needle of a 30 gauge with thin wall, because we can put exactly the loop inside the wall, and the tunnel can fixate in a good manner the loop with a low tilting of the IOL. Finally, the consideration is that one of the advantages of the Yamani technique over Carnival IOL is in the case that you show us with the retinal detachment, because Carnival IOL is a acrylic hydrophilic IOL, and so a tamponade can damage the IOL with the opacification. So you show us a very fantastic surgery, and I thank you for your surgery.
Thank you.
Thank you. I'd like to ask any of the audience members or any of the other panelists or speakers if they have any questions or comments.
Arjun, can I make a comment?
Yeah, please go ahead, Ashraf.
Dr. Mendelcon, amazing surgeries. I think we as surgeons don't appreciate the surgery of Manis technique as well as we celebrate the other Shariat Gabber's technique. But I just want to highlight 2-3 points which was published in 2017 paper by Yamane. So basically, in Japan, they used two IOLs, that is NX70 and VA60 from Hoya and Santen Pharmaceutical, respectively. So the NX70 at PVDF around 78 eyes, and this PMMA was 22. So the only two things which I wanted to highlight was they made a 0.3 blob. So that is not very we can't measure it, but they use a 30 gauge needle to externalize. So if the thinner the needle, then the blob is enough, even with PMMA haptics. But otherwise, it's a very elegant technique. And they studied around 100 eyes, and none of them had any dislocations, as we have in SFIOLs. None of them had, and the tilt was only around 3 to 5 degrees. It is a very elegant technique which has to be done and executed well, as Dr. Mendelcon showed us. Once you do that, I think it is quite a minimalistic, very elegant technique to practice.
Thank you. Yeah, just a comment. I do use the thin walled needle, and you can use a 30 gauge or a 27, and I use the 27. I use the 30 as well. It is a little bit easier to tuck the 27, as you can imagine. I haven't had much issue with the ball being too large with the 27. Probably you're right. It needs to be a little bit bigger. But yeah, it is. There is a learning. I mean, the previous presentation was excellent. I've done the glute IOL with the flaps. I do think once you get this, it is quite easy, and it's quite quick. And as far as dislocation goes, as you mentioned, Ashray, it's when if you want to exchange this type of situation, so you have a subluxed, or it's tilted and you want to redo it, it's actually very hard to get the haptics out of the sclera. It's so fixated that you can't pull it through internally to remove this type of implant once it's fixated. You have to externalize the haptics and cut the bulb and then remove it. So in other words, the bulb is so tightly embedded in the sclera that it won't dislocate. It's even hard to remove when you try to pull through it. So I do think, yeah, it's the dislocation issue is probably for sure less of an issue than in other scleral flaps.
So another important aspect is, as retina surgeons in an era of refractive surgery, we should respect conjunctiva. In fact, the technique which Mandercon exhibited, respecting that conjunctiva and maintaining that integrity and its surface is very important. That's why I said we don't celebrate the M&A technique as much as we do with the Charette-Gaber's technique, but a very elegant technique. Once you master, it's gives a lot of good results.
Thank you. Oh, you're muted, Arjun. You're muted. Arjun, you're muted. You're muted. Yeah.
Oh, sorry. We have a question from Dr. Sarang Hansraj. He's asking, what is the effective lens position you use for the IOL power calculation? Do you consider it as a sulcus lens or a in the bag lens?
So I do 2.5 millimeter from the limbus, and I do consider a sulcus because I find that when you just do a regular aim for emetropia or the first minus on the IOL master, it's usually it's a myopic result. So I'll go the first positive after emetropia. In other words, I do aim for sulcus, and the results are reasonably good. Again, I think most of these techniques, you're going to have a little bit of astigmatism, etc. I think once you get this technique down, and you do actually aim for a sulcus, your results usually have very minimal astigmatism, and the sulcus, the aiming for the sulcus actually helps significantly, keeping it close to emetropia.
Arjun, I have a comment. Arjun, may I go?
Please go ahead. Please go ahead.
Actually, we have done, in fact, I'll be presenting as part of my presentation. So actually, when doing scleral fixated at IOL, the confusion is always there. So in fact, we extensively studied in the last 5 years and measured effective lens position post-operatively. In fact, we did 2 studies of almost 150 eyes, and specifically for one of the recent studies around 50 eyes, and measured the effective lens position post-operatively. So in Barrett's universal formula 2, what happens is they have a regression analysis formula it is. So they have there are 5 parameters. I will talk in my presentation. One of the parameter is the axis length, which plays a big role in the effective lens position, and the theoretically predicts effective lens position from the range of 4.5 to 5.5. So the normogram which we have come up across is, if you are doing a 2 mm sclerotomy, then you can definitely use the Barrett's universal 2 formula directly and implant the same IOL power without deducting or this thing. I will show it in my presentation, but that is what we have arrived at mathematically, and how we have arrived, again, I'll be happy to share that in my presentation.
Can I make one other comment, Arjun? There's a question in the chat about not using glue and chance of decentration. I personally don't see how the glue will, maybe, I don't know. I did use the glue for a while, years ago. The centration, I don't think relates to the glue. It relates to the, number one, the placement of where you put your sclerotomy, your scleral tunnels, if they're directly opposite each other at 3 and 9, and that marking is very relevant. And that's probably why I don't like to block with any chemosis, because I want to make sure I have as much view of the conjunctiva as possible to ensure centration of my scleral tunnels, or my scleral tunnels, number one. The other part of decentration is the manipulation of the haptic optic junction. If you pull or push too much on one side, you can actually stretch that junction, and that will tilt the implant or decenter it. So that's partly why when I externalize haptics, I bring out the haptic and I tuck it back in the eye slowly so that I'm not pulling one side too much and then destabilizing the other haptic optic junction. So that's also decentration. And the final thing I want to say is that, and I've done this before because I've seen this at meetings, where if there is a little tilt in the implant, I'm not sure anybody's tried this, but I have tried it recently. If you use a regular endo laser, like you'd use for any retinal laser, and you just point that directly over the haptic optic junction where the optic meets the haptic, and you, under long duration, like you're sort of cooking it with heat, you actually can stiffen the haptic optic junction significantly, and you'll find the tilt will go away, because the tilt is often because there's weakness in the haptic optic junction. So just using a laser and heating that up, that improves the bond there, I guess, or stiffens the junction, and the implant will no longer tilt. So if you're really stuck in a case and you have lots of tilt, I suggest you try that. I think actually it's a very easy fix for tilt.
I have a question for you. What about iris capture and how do you manage it?
It's an issue rarely. I would say maybe 1% to 2% of my cases have, maybe 1% have optic capture. Number one is I always do an iridectomy. I didn't used to do that. I find that number one, that helps mitigate that risk. Number two is when that happens, I will put the patient on pilocarpine, in the office, and I will do 2 extra iridectomies. And I think in almost all cases that resolves the issue. And then eventually you wean them off the pilocarpine. I have one patient who I've done that, 3 iridectomies in different areas. He still captures when he's in certain lighting conditions, but he's 20-25 and he's very happy, right? So I found that it doesn't always affect their vision too much. But generally, I think increasing the amount of flow through the iris, because there's often can be some iridogenesis, you can reduce that risk of capture.
And those were some very nice surgical pearls you shared regarding the decentration and tilt and even the iris capture. And we'll move on to the next presentation by Dr. M. Nivian on the CMT Flex IOL. Thank you so much, Dr. Mandelkorn, for those wonderful cases. Dr. Nivian, you may please
Arjun,
share
can
your
I
slides.
ask one question?
Yeah, please go ahead,
Meanwhile,
Dr.
he's loading. Yeah. So for all the presenters, how common do you see uveitis in your post-op patients for both the techniques? Do you see them often, or it's not that common that you see recurrent uveitis or otherwise iritis?
I mean, I would say I don't see that very often personally. I do see CME, and that's maybe at least 10% of the patients have CME. And I'm not sure that's from the Yamani itself. I mean, it is from the Yamani, but I'm not sure other techniques have less. Again, like I think when I've the patients that I've had with iris fixation, I think the rate of CME is higher. I don't have my data available for that offhand, but I would say the iritis question and actually cells and vitreous cells, etc., is extremely rare in my hands.
Yeah. So if I can add to that, with the technique that I showed, I can also understand why the technique with the Yamane is a little less as shown, because the point of insertion or the externalization is at 2.5. So the closer you come to the root of the iris, your risk of uveitis is slightly higher. So I initially started off at 1.5, and then seeing the uveitis in those eyes, I moved back a bit to about closer to 2 mm from the limbus. So at 2 mm, now practically I do not get, the rate of uveitis is very, very low. CME, yes, as I showed, I have an incidence, one of the common complications with any of the SFIOL techniques you will see. But if you are too close to the root, you will have your recurrent uveitis.
Thank you so much.
Thank you. Thank you so much for those answers. Thank you for the question, Dr. Ganesh. We'll now ask Dr. Nivian to please share his presentation and we can go ahead with his talk.
Thank you, Arjun. Is my screen visible?
Yes, it's visible and your video is audible too.
Sure. So respected teachers, senior ophthalmologists, my dear friends. So I'm Dr. Nivian from MN Hospital, Chennai. So I'm going to talk about CMT Flex IOL as a new option for aphakia. So I do not have any financial interest. So the whole question arose 8 years back when we had these different techniques of non-sutured IOLs like the glued IOL technique, the emanate technique, and XNIC technique. But the idea was all these techniques were modifications of the existing 3-piece IOL. So that is why we wanted to have a lens design that is unique for the scleral fixated technique. So that led to the birth of the CMT Flex IOL. So it's basically a single piece hydrophilic lens with a specialized T-shaped haptics on either side. So I'm just going to go through 3 surgical videos to show how it's done. So this was a case of a microspirophakia. You can see a 360-degree subluxated lens. So it was planned for a vitrectomy, lensectomy, and a secondary CMT flex. For any, I think, secondary IOL, I think the 0-180 degrees marking is very important. So after that, we make a 2 by 2.5 millimeters partial thickness scleral flaps and 1.5 millimeters away from the limbus. Using a 23 gauge needle, a sclerostomy is done. So here I had to deal with the lens too, but since this was a it's a soft lens, so I used the needle just to stabilize the lens, and then with my vitrector just made a hole in the back, and with good suction and cutting, I think I was able to do the entire lensectomy, making sure none of it fell back. So as we are surgeons, we know once it falls back, then the entire scenario changes. So once the vitrectomy is done, as you can see here, it's a single piece foldable lens. So this goes into any of a normal foldable cartridge. So the only thing here is we make sure that the T junction goes in first. The second advantage, as you can see here, is it can be done through a clear corneal incision using a regular foldable cartridge. So when we inject, we just make sure that the T comes out first. So then it makes it easier for us to grasp. So once we grasp the neck, as you can see here, the neck portion of it is actually grasped. We did not pull the IOL because it's a single piece lens, and then that time is when it can actually break or tear. So I'm injecting the remaining of the IOL. So you can leave the trailing haptic either over the iris or at the wound here. So once the lens is free from the cartridge, you gently pull it out. At the sclerostom, you'll get a slight tug, but then when you see the pop of the T, so it's basically again because of the design, so it just avoids the extra thing of doing a tucking or a suturing of these haptics. Again, just a small animation clip. It can be done in any regular IOL cartridge, but just making sure that the T is pointing down so that that comes out first. So we also have specialized forceps for this. So it comes as a T-flex forceps. So basically you need a broad but non-sharp forceps to hold it because of the hydrophilic material. If you use any of your sharp via forceps, it can bite into the material, and that can again cause breakage of the lens. So just gently bring it out and it opens in. For the other side, yes, we use the handshake technique. So we here hold the arms of these lenses, and because of the materials, it's very flexible and it's easy and it's very tissue friendly, as you can see here. So just exchange it to the other hand and then pull it out. Just wait for it to slip. Don't give too much of force trying to pull it out. So once the second haptic done, again the advantage is it fixes exactly where you measure your 180 degrees, and then that is also again going to avoid the tilt. And then the flaps, initially we were gluing the flaps and the conjunctiva, but because these haptics are thicker than the usual three-piece lenses, there is no leakage from the sclerostomy. So basically you can even cauterize the conjunctiva. Some people even prefer to suture the conjunctiva. These are some of the immediate post-op pictures of day one of the lens. You can see nice round pupils. These were 1 month post-op pictures. We did studies on the UBM and OCT over the sclera just to see the long-term stability of the lens. So right now I think we have a published article about a 7-year follow-up study of 100 lenses of these lenses. So moving on from all the applications, so these lenses can be combined with various other techniques also. So you can use it with SFT and other techniques. So this was a young patient who came to us which had history of trauma 10 years back, and he also had a secondary glaucoma. So basically he was planned for a trap surgery along with a secondary IOL. So here the glaucoma surgeon actually performed the trap superiorly. You can see here the flap being the mitomycin C being applied and the punch being done and the releasable sutures. So the other advantage here is you can see here once we make the flaps, for any secondary IOL, I think a vitrectomy, a good clean vitrectomy is needed. So most of the times I try to stain the anterior chamber with triamcinolone austenite before doing a vitrectomy. So these are the two special instruments. For one is for exchanging, I could see just has serrated edges so that it grasps the IOL nicely. And these are the T-flex forceps. So there has a broad tooth in the center, which makes it easy to hold the T haptics. As I said, because they did the trap superiorly, I made the clear corneal slightly away. But this made it easier for me to feed the lens directly into the forceps rather than going at a 90-degree angulations. So as you can see here, the T coming out first, so holding the lens, and then again not pulling it out, just injecting the remaining of the lens. Make sure the lens is free from the cartridge and goes slips under the iris. So once the lens is free, as I said, and then start pulling it out gently. The first part is easy because no matter how much force you give, it will always come out and you're sure and safe it is popped out. But the second side, I think, is a small learning curve. Like for any secondary IOL procedures, you can't give too much of force. It is the force that is actually sometimes brings it out to cause breakage. So just wait at the sclerostomy for it to slip out. See there, just wait for it and then it slips out. So in this particular case, because of the trauma, you can see there was a large sommering ring there that is there. So I didn't want to leave it out. So gently just maneuvered it to the antechamber. As you all know, sometimes it's very difficult to remove the cutter because of the calcified component. So basically just lowering the bottle height, using this T-flex as a scaffold, and introduced my phaco probe and made sure the entire sommering ring was emulsified, as you can see here. So sometimes it's advisable in any of the secondary IOLs, don't leave any of the remnant capsule or the bag. It is always better to clear it to prevent further fibrosis later on. So once the ring was removed, you can see the pupil is slightly disfigured, but this is from the previous trauma and all the synovial adhesions. So using the synovial cannula, all the adhesions were just cleared. The corneal adhesions were just cleared. So once the adhesions were removed, you can see the pupil starts to become round, but you can see an old scar on the conjunctiva where the trauma was and patient was sutured previously. And then I usually end up putting air in the antechamber. You can see the bleb superiorly. So this was the post-op weak picture with a nice filtering bleb, and also a well-centered IOL and the old scar that can be seen. So moving on to the next segment, yes, complications are common. Like you can cause breakage if you use sharp instrument of too much of force. And in our study also, we had some amount of iritis and glaucoma, but it was almost comparable to any of the secondary IOLs. So moving on, since many people are doing that we just came up with some of the tips that we usually like to share about doing the CMT flex IOL. So the first thing is, initially I was doing all the sclerostomies using the needle. But now slowly we moved on to the MVR blade and we started making perpendicular incisions to the sclera. So basically, because of the T-shaped thing, so when we make these perpendicular incisions, so the T actually sits at 90 degrees. So there is less chances, as you can see from the picture 1 to the picture 2, when you make it at 90 degrees from the limbus. So the T sits at 90 degrees, so less chance of slippage. We also have a 10-degree angulation on the lens, as you can see here. Basically, it sits like a hammock. So this is what actually prevents it from going close to the iris and causing any irritation of the iris and dispersion of the pigments or causing secondary glaucoma. So as you can see here, it's like you can just put it on your hand and see whether it is a concave or convex. And so depending on the angulation, you place it. And we also have these marking holes to make it easier for us to know that the angulation is there and which side the lens is coming out. The third thing, as I showed in the first video, we were holding the neck, but then it was slightly bulky to bring it out. So now we call this what is called as a head-on position, as you can see here. So basically what happens in this head-on position is, if you're able to hold the lens like this, and when you pull it out of the sclerostomy, the T actually bends inside when it hits the sclerostomy. So you have a lesser diameter of the T, this thing that actually comes out. So this makes it slightly smoother for us when we pull it out. So this, we have named it as the head-on position. As I said, we have all these dialing holes. So sometimes some surgeons use the dialing holes to exchange the haptic. And the other question that was asked is, can anterior segment surgeons use this? Yes, you can use it. I think use a trocar maintainer like you can do for any other surgeries. So this was another case where I had a rigid lens which was dislocated along with the bag. You can see the crumpled bag. So we did a sclerocorneal tunnel. So you can see the AC trocar maintainer, again invented by Amar Agarwal. I think he's got a man of all inventions. So once the basic thing is, make sure that there is no hypotony in any of these secondary IOL procedures. So once we have it there, so we make the sclerostomy 1.5 or 2 millimeters away from the limbus. So here again, we just slightly modified. We also use the trocar sometimes. So as Ritesh said, it's easy to do the vitrectomy also through these trocars. So before removing any of these IOL, just make sure all the vitreous adhesions are removed from the IOL before you actually remove any of the lenses outside. So it is freed of its adhesions. So as you can see here, again using the injector. So that was also told by Nesar, because I always feel you have more controlled action when you use the injector rather than just trying to push the lens inside with the forceps, because then you're trying to open up this thing. And for the nasal side, we have come up with the bent instrument also, because some of the surgeons said nasal is sometimes difficult. So we have a bent instrument also, so that can be used for the nasal bridge. Here again, you can see the head-on position of holding the lens. So I use the trocar itself. So the only difficulty is you will have to make sure that the trocar comes out first, and then you're actually seeing the T-flex come out. So that can also be done. As I said, centration depends basically on how you fix the 0, 180 degrees. And this also can be done either horizontally or vertically, depending on which part of the conjunctiva is good and depending on all the previous surgeries. So as you see here, once it is done, the AC is removed. So we have a short 7-year follow-up now. So once again, I could like to thank Arjun and Atul and the entire ASG team for having me here in this wonderful webinar. Thank you.
Thank you for that wonderful presentation, sir. Very elegantly shown cases, very nicely shown cases. And I'd just like to ask our panelists about their experience, Dr. Vayanu in particular. How different is the IOL platform which you use from the one which Nivian sir has just shown? And I'd like to ask any of the other surgeons here who you do the CMT Flex IOL as well about for their questions and comments.
Yeah, I have a question. You show us a amazing surgery, very compliment for you. And what about the rate of the break of the T anchor?
Yes. So initially we did have a breakage of the neck portion of this thing, but I think it is because we trying to hold it too tightly because we are scared of it slipping back inside. So because of the material, it goes bites into the material. So nowadays I think we just hold it gently, making sure that it does not slip, and we avoid using any sharp instruments because some of the surgeons don't buy the specialized forceps. They use their VR instruments. So sometimes if it is sharp, it can actually bite into the material.
In my experience, the rate of break of the T anchor began lower when I full open the IOL in anterior chamber or in posterior chamber. By mean a handshake technique. I think that we can break the T when we push the T anchor while we push the IOL in the cartridge.
So you keep the lens in the anterior chamber and then take both sides out. Okay.
Dr. Nivian,
or in posterior chamber while I fix it with a crocodile pinza, and with the other I can manage the IOL in the good way, in the good manner, no, to push out.
Yeah. Dr. Nivian, I had a doubt. I mean, I used this CMT Flex initially when it was kind of launched. From then till now, has something changed in terms of the neck length or the material? Because I had not a couple of good experiences because I found that pretty brittle and it used to break in my hand at least. So has there something? The neck seems to be a little shorter than what it was initially, which was launched, and
Excellent.
the material. I don't know what is your opinion on
So we
that?
came out to the first generation of the IOLs, and then we had these problems. So we had to make it slightly thicker. At the same time, it was basically we learned about the water content of the lens, so that makes it more flexible. So one of the reasons, so we had to do some flexibility tests to see how much it can stretch before it breaks. So that basically again depended on the water content. So the next generation came out thanks to COVID. So after I launched it in 2019, COVID struck and I could not release the lens. So that gave us time to do slight modifications, like you said. So I think now we should use the newer generation of the lenses and give me your feedback.
I think I need to use the newer one. I have not had the experience. Thank you, Nivian.
Can I ask,
I
which was the year that the
I want
Caravella
to.
started? I'm sorry, go ahead.
I want to share with you another things. I now, for me, it's very important to do iridotomy because I've seen in my experience a lot of reverse pupillary block, and in some way and now I am studying if this is related with the macular edema post surgery.
Is it something to do with the type of iris also? Because sometimes we have rigid iris, but sometimes in the secondary IOLs, the iris is floppy. So have you seen it more with the cases where the iris is floppy, has more chance of pigment dispersion and...
Yeah, another thing. I usually perform the surgery with sclerotomy at 2 millimeters behind the limbus. And until now, I think that more posteriorly, I think 2.5, 3 millimeters is better. But in the last cases, we have a lot of reverse pupillary block. More posterior, more pupillary block is a situation that you said.
Correct. Because if we go more posterior, the lens tends to come slightly more up.
Any other questions from the audience members or panelists? We can take one more question before moving to the next topic.
I think
And
more
I
people
want to
should
say
start.
another thing.
Yeah, please.
I want to say another thing that Yamane techniques wonderful, but in more complex cases, when we want to add an other surgery, I mean glaucoma surgery, corneal surgery, Carlevar lens or T-flex lens is better because more larger, like a platform that can separate it posterior chamber with the anterior chamber. So a gas bubble or other thing we can perform combine our surgery better than with other secondary IOL implantation. What do you think about it?
Yes, I too agree with it. We do a lot of trauma cases where we have to do iris repair techniques, nucleus drops with vitreous hemorrhages. So I feel in those kind of cases, this is a more bulkier lens than the other this thing. No, so it gives more stability, and there's no question of rotation or torsion once you fix them, I think, and less chance of leakage. And post-operative hypotony and vitreous hemorrhage has been very less. So in our study, what we found is the chances of vitreous hemorrhage, retinal detachment secondary to the secondary IOLs is comparatively lesser compared to the other techniques.
Thank you for those excellent discussion points. We'll move on to the next talk by Dr. Ahmed Mansoor, who's joined us from Egypt. He'll be talking to us about the Canabrava IOL fixation technique. The floor is all yours, Dr. Mansoor. Thank you for being here.
Hello, Arjun. How are you? It was my pleasure meeting you in the States, and actually, I'm very welcome to be looking forward to all these talks. I'll be talking about the Canabrava after all of these immersive talks. So I'd start sharing my screen now. Is it okay? It's shared?
Yes, your screen is visible and you're audible.
Okay. So my talk will be about the four-flange interscleral intraocular lens fixation. This technique was by Sergio Canabrava in 2019. And actually, my first and always choice in the IOLs is the iris claw IOLs. And this comes next if I have shortage in the iris claw IOLs because of something related to my OR or something related to the availability of the powers. So the core mechanics we know about the thermomechanical flanging, utilizing the shape and the memory properties of the polypropylene, and the cauterizing creates the flange stop that we use. And actually we have just 4 flanges, 2 in each side, one in the IOL and the one in the sclera, and this bidirectional stability locks both the IOL and sclera. So what's my indication for the Canabrava IOLs? It's actually aphakia, no available iris claw because it's my first choice. And second choice is the compromised back during surgery, especially if you're having large wound, like after rescuing a hard cataract or after complicated echo with one of the fellows or something. And this happens intraoperative complication where you don't find the power of the IOL. Trauma, especially if this trauma was a penetrating trauma and compromising the iris, or in cases of IOL exchange. So my precision kit for entering any of these cases is thin-walled needles, 29 gauge or 30 gauge hypodermic needles. And I always check if the lumen is working by injecting a fluid. I let my nurse inject a fluid from the plunger itself to check that the lumen is already allowing the flow of the proline through it. I use a 5.0 proline for this 6.5 PMMA IOLs, and I like to use the low thermal cautery like our doctor said from Australia. And because of the high cautery, I had a problem like this before, so I'm going always for the lows. And these are my golden steps. These are my 8 surgical steps for the towards this IOL fixation, I start with phase one, which is the preparation, the wound construction. Either you do it corneal, but with a long tunnel for the IOL, or which is better, which I like to use, is a conjunctival periotomy if it's scleral tunnel, and then anterior vitrectomy. And this should be a very, very good anterior vitrectomy for a VR surgeon. You know, this is a very important to do it like this. If you can do a complete vitrectomy, okay, but it's not crucial. And again, the tunnel, you do the tunnel at 180 degrees, and you should be sure that it's from the corneal apex itself, not from anywhere else like we're showing with the marker. And then the phase two is the IOL placement. We suture threads, they can private pass, as you can see, and then we'll do the IOL insertion and the centration, which is very important. And then we extrude and cauterize the flange, and then the period of the flange, and at last we do the wound suturing, AC formation, and checking for stability and centration. So this was my first case. It was my fellow's case, and he's doing great with the extra cap. And then we found this is a compromised bag intraoperative, and I asked for a Versailles, which was not there for ISCLO IOL. So I started, but it was not prepared because it's not planned for. So as you can see here, it was an extra cap when combined with the drop nucleus, where he managed well, but you see the trokers are compromising everything here because of my entry. But one of the things, I go at 2 millimeters from the sclera, like we said, because of the iris, and then I pass the Prolene needle, and then I start again from the 180 degree again to manage to getting the needle outside from the wound, and again passing the Prolene from the other side, as you can see in this part. And actually you need to get a very long thread inside the needle in order not to slip from the flange while you're going. And then I pass it one from the needle, as you can see this Z-shaped, as you can see the IOL, both from same side because I did it in the first part in the wrong side. And then you flange the IOL, big flange, in order not to pass from this eyelet, as you can see. And then you get the IOL inside. One of the things I did wrong here is the entanglement of the flange while entering inside the eye. So when I'm trying to pull over the IOL, you will see something happening. Now the IOL was entangled, and then it flipped and went to the usual position, which is okay. And then I cut it short, flanged the needle. I didn't have the low thermal cautery, so I used the usual one where you can use it again. And then I managed to shorten the flange and then cauterize again. This was actually my first case. The patient went well, the astigmatism was around minus 0.75, everything went well, so why not to do this technique again? So this is a planned surgery. It was a phakic patient, and the Versailles or the iris claw was not available, but at that time I managed by measuring the 6.5 millimeter, 7 millimeter, and then the 2 millimeter from the limbus, and then I opened the periotomy again and doing my scleral tunnel after doing very good diathermy. And one thing I like to do in all cases that I like to put infusion, either you put, my preferred is to put a posterior chamber infusion like the infusion cannula we use in vitrectomy, but in this part I did put the anterior chamber. I want to show something that you can use it even for the anterior segment surgeons. And then I released the adhesions in this complicated surgery, and then I entered do a thorough anterior vitrectomy, and I like to put kinacort sometimes in this part to be sure there is no vitreous loss, there is no vitreous entanglement or anything, and do almost a complete anterior vitrectomy in this part. And then I open with the crescent, as you can see in this part, and start again entanglement with the needle inside the eye. One of the good things that you should know in this part, that you go with the needle outside in order to not to be entering inside the corneal tissue itself, and this would be hassle if you entered the Prolene and did the flange. You may revise the whole surgery for this, so get the needle outside. And again, the looping you need in the flanged IOL when you go with the tunnel 2 by 2, you don't need it in this sport. You can go directly from 2 millimeter from the tunnel. You don't need that tunnel you need in the flanged IOL or the Yamani technique. And again, as you can see, I'm putting the flange, I'm putting the Prolene IOL through the eyelets of the 6.5 millimeters IOL, and then I put the flange again and do the diathermy. Most important thing in this part, that you not take the right Prolene for the left and the left Prolene for the right, because if you did so, you will try to cut again and replace the flanges. And this good thing with the Prolene, if you have a mistake with the Yamani, you need to replace the IOL. But actually, if you did a mistake with the Canaprava IOL, you cut the thread and then rethread again. And as you can see in this part, I removed the infusion cannula, led the patient a bit to the hypotenuse side in order to be very stretched, closed my wound, and left the flange, the Prolene needle outside, injected my coal as the usual to do proper centration, close my wound. And then, as you can see, I can cut very flush to the sclera, and then I do the dithermy. It's round. You're catching the needle from 1.52 millimeter from the thread at the end, and the same for the other part, and the patient went very well. But this was more complex case. This is my last case. It's my complex case. It came complicated after 3 to 4 surgeries. They tried. It was complicated by complicated cataract, and then they did IOL repositioning. They removed the IOL and put another one, and it came to me like this. Vision was counting finger 1 meter and referred from one of the senior staff I have in my department. And then I planned to do a Canaprava IOL because I was planning to do every size, but I found the iris is compromised in this part. So I dislodged the IOL and the capsular bag, which is completely compromised in this part. I cannot fix it in this hydrophilic IOL. I don't like them. I like to have the PMMA material. So I opened the wound 5 millimeter again, 7 millimeter again, and I entered inside. Opened the whole wound. I extracted the IOL because the cornea was very compromised. I didn't need any compromise. As you can see, I'm putting the cannula even to protect the endothelium. After removing the capsular bag, I started even using the forceps, 2 forceps to remove it, and then I use the forceps and scissor to cut it off the iris. The patient has been like this for 1 year. I started by suturing the wound, doing very good pars plana anterior vitrectomy. And then the same way I did put Kinacort, ensure there is no entanglement of any vitreous. I did this from the cornea surgeons to mark my center, and this is my rule now, to mark the apex of the cornea, and then put my 2 by 2 millimeter mark, so I can go with the flange as you see in the other part. One of the things I'm doing now, I test my cautery before doing anything, before putting the IOL in the trocar, and I'm showing here the around 90 degrees cannula I'm putting inside, and I'm putting the flange again inside and the Prolene, and getting from the other part, and doing the same part. We can even superpass this for the next step. As you can see, I'm entangling the same part here. I'm sorry. And then I'm testing the centration, and again cutting this part and putting the dithermy. And one good thing with the Canaprava, after you can finish this, you can deal with the iris. As you can see in this part, I'll be doing a pupilloplasty for this patient, checking the retina. Always as a VR surgeon, I don't compromise this because the patient has multiple surgeries. So I entered inside and checked for the aura and the vitreous base, and then doing for pass through this iris. I went inside and then did the pupilloplasty in the upper and lower part. And as you can see, this is the part entering inside and getting the loop and doing my 4 pass-through. And the irises went. This patient improved vision to 6.9 post-operative. We were talking about a 0.7 vision, and he was quite happy with this. And centration was about 0.5, and this is something I like in this ILs rather than the Yamani technique. So this was a 5 years clinical study and stability success and it was published in GCRS in 2023 for 71 eyes. The mean follow-up was about 2 years, and eye stability was around 99%. No sutures degradation, and the visual recovery it's increased around 48%. And one of the good things that he can use, and actually I'm not having this luxury because I don't have both IOLs, the eyelet, 4 eyelets IOL in my country or the shoelace IOL in Egypt. These are the IOL modification made by Canaprava, by Sergio Canaprava, where he used the 4 eyelets IOL and the shoelace IOL concept. You can use it even in the CTR, CTS, and we use it in the flange. And the iris IOL and artificial iris fixation, like we said with our doctor from Australia. But one of the disadvantage I have here is the large wound a bit of decentration for sure it can happen if you compare this to the retropupillary or iris glow IOL, and it's a bit of time consuming and need preparation in comparison to my preferred iris glow IOL. So if I have the most choice, I would use the iris glow IOLs, but if I don't have my choice, it's my first to go. And thank you.
Thank you so much for those cases. And this looks like a technique which is rather cost effective. And I think that is something which is very relevant in the practice setting, especially in India. And
Yeah.
it's looks a little tricky too, but like you said, it needs a little more preparation. And I think it leads to good outcomes like you showed us. I'd just like to open up to the panelists and the audience if they have any questions or comments regarding the videos shown.
Arjun, just a very interesting observation here. You see that proline sutures, the kind of what Ashray was talking about, the kind of knots that you can get with regards where Yamane technique, which is also done with PVDF or proline haptics, that is the kind of the stability that proline can give you, which typically PMMA with PMMA it may not always be possible to get that nice bleb which doesn't fall back into the eye. So the proline with proline you can see that nicely happening.
Yeah. And actually, I will answer for Arjun for this. Yes, this is a very cost-effective technique, and actually, this happens a lot in Egypt when you don't have the three-piece IOLs. And actually, had a bit with the situations happening around the world. We had a problem with the importing and exporting of the IOLs, so it was very, very cost-effective and always available 6.5 IOLs, and it's very, very cost-effective. Second thing regarding the proline stability, yes, it's very, very stable. It's more than the PMMA. It's better than the, with the Yamani, if even you're doing in the classic technique or even you're doing with the trocar assisted technique, you may have this tilt of the IOL, the tilt of the haptic, you make a little bit of decentration that everyone is complaining about. This doesn't happen with the proline.
Thank you so much.
I think just another comment to add, Arjun, if I may.
Yeah, please go ahead. We'll take this last comment, and
Yeah.
I think
So,
Ritesh sir can start loading the screen in the meantime while we discuss this.
yeah. So the comment I like proline suture, we have a lot of length. So the recommended blob, which is 0.3 the diameter, can be achieved by doing a lot of cautery to the length which is already there in this suture. So but in haptics, it might be very bit tricky because we have a limited material. So on contrary to that, we are talking about using like how close we are to the iris, which can cause uveitis and pigment dispersion and all. So in this era where we are on one end we talk about refractive like outcomes, so iris clip IOL becomes quite a question mark for me in day-to-day practice when such great techniques like what all the speakers have alluded to, such great techniques are available. I really question myself and even ponder over why we should be doing iris claw as a regulation, because that is been followed across a lot of practitioners. So that is something which I would like to put in your thoughts, whether it is really needed because we have such great techniques.
Thank you so much for those points. I think we can continue this discussion in the
Hi.
chat box. We also have two
Hi,
questions
Arjun.
from Dr. Vipul Prajapati. Yeah, somebody's saying something. I'm sorry if I was interrupting someone.
Yeah. Hi, Arjun. Yeah. Can I just ask a question, Arjun?
Yeah, please go ahead.
Yes. Yeah. Sir, this question to my seniors. Sir, regarding the XNET procedure of SFIOL, has anybody has an experience of it? I would like to know, in cases of complicated pseudophakia or a complicated cataract, what would you prefer? A staged procedure, like leaving eye for aphakia for a while, for 1 or 2 weeks, and then proceeding with the SFIOL? Question number one. And then second is, I would like to know, do you monitor the size of the blob when you are making a blob on a proline versus on a PMMA? haptic of the IOL?
Arjun, shall I
Two
answer?
very nice questions. Yeah, I think
Arjun?
Ashray sir, if you could just take these up in the chat box of Dr. Ahmed,
Yeah,
and if Dr.
yeah.
Mansoor and Dr. Ashray could just take this up in the chat
In the
box in the
chat
interest
box,
of time.
yeah, yeah.
And we'll start with Ritesh sir's presentation on the aniridia sutured SFIOL. And Dr. Vayano has recently worked on the aniridia carnival IOL as well. So please go ahead, Ritesh sir, and we are looking forward to this talk as well.
Okay. Thank you, Arjun. Between such interesting current techniques and the future, which is going to be talked about by Ashraya, uh, I'm going to talk about sutures now. So I won't call it a dinosaur technique, but something which I got trained during my fellowship. I use it less often than what I used to use it earlier for, because mainly you moved to, as I said, there are a lot of issues with suture. And when I look at my indications over the decade, where am I using sutured SFIL now, in the order of my cases done in the last decade, the most common has been refixating a previously subluxated sutured SFIL, where one side of the thread has broken and I don't want to explant those large PMMA IOLs. I just want to ab interno refix it. That's the most common usage of the suture which I do. I'm using 90 proline just to put it here now. Earlier we used to use 10-0 proline. I've some moved to 90 proline now. Second most common indication which Arjun wants me to talk about in the surgical technique is the aniridia SFIOL, which I'm going to be showing the video on. Aniridia SFIOL is a large IOL used for patients which have both aphakia and aniridia, typically post-traumatic, in which I use this aniridia SFIOL. It's a customized SFIOL. Uh, I know of one company which I order it is from IOCare. Place an order. It typically takes 2 to 3 weeks for them to give this IOL to us. It's a large optic IOL, about 10 is the size of the the whole optic, with the periphery being pigmented to simulate the iris. Some relative indications like large white to white eyes, which was discussed previously, conjunctival scarring, scleral thinning. Slowly, I moved in these indications from sutured earlier, which I used to do, to an iris claw IOL if the iris is healthy. And the sclera is extremely thinned out. I'm even worried about using sutures in those eyes. So from this, where my indication is, I'll quickly move on to the technique. There are two techniques which have typically been described for suture IOL. The 2-point fixation, where there are only 2 points on the sclera on which the IOL typically hangs, and a 4-point where there are 4 entry points and they are used for fixation. So there's a 2-point versus 4-point, 4-point being providing a little more stability. Typically for sutured SFIL, we used to order the special IOLs with an eyelet, whether aniridia or non-aniridia. And in my video, I'll be showing the aniridia SFIL. So starting off with the video, typically again, starting the surgery with marking my 3 and 9 o'clock position as I do it for all cases of SFIOL. Didn't get a great mark. I'll probably be repeating it in the further surgery. The conjunctival opening herein required is a little smaller than what we require it for a glued IOL technique, at least at 3 and 9. But I'll need a large conjunctival opening at 12 because this IOL needs to be put in. So this large conjunctival opening to allow me to make a good large scleral tunnel. Again, remarking the 3 and 9 because I didn't get it nicely in the previous one. Don't want to miss out on getting the position right. Instead of making flaps, I'm going to be making just scleral grooves or scleral pockets. And I'm going to be using those pockets to kind of tuck in the sutures once at the end of the surgery. So pocket at 3 and 9 o'clock, starting at roughly 2.5 millimeters from the limbus, which will give me an entry into the eye at about 2 millimeters. So pockets here. Now the IOL is 10 So how do you get a large tunnel like that? So I make a 7 tunnel with a 2 back cuts on either side, putting my infusion cannula. I'll move forward to, so that's the large tunnel. You can see a 7 tunnel with 2 back cuts on the sides, allowing me enough space for putting in a 10 IOL. So now passing the suture, this is the proline suture. passed into the pocket using using a handshake technique or a railroad technique with a 26 gauge needle in the other hand. So railroaded, got it out, and now I'll pass it through the eyelets in the IOL. So that's the eyelet in the IOL. That's the large IOL I was talking about. Pass it twice. So what I do is on one side I'll pass bottom to up, and the other side I'll pass from top to bottom to kind of balance out the torque as you pull this. Then you pull out the needle back out through the same pocket. So this is done on the one side, and then I'll move on to doing the same procedure on the other side. Oops, I think sorry. Yeah, so I'm doing the same procedure on the other side. So yeah, so getting this haptic out here, sorry, the needle out here. Yeah, getting this out, and then the previous side I had gone down, up, and this I'm going up to down, moving it twice through that loop, balance the torque. Again, using a railroad technique through a 26 gauge needle, getting the needle out through the last tunnel, putting the thread back in. Subsequently, positioning the IOL in place, make sure that the threads are not tangled to each other, slightly enlarging the tunnels on either side. I don't want this IOL to get stuck in the tunnel. Then placing the IOL into the anterior chamber, slowly letting it fall back into the eye. It's a vitrectomized eye, so I'm not too worried about it mixing up with this. Giving it a little nudge, pulling the haptics on either side nicely. It's a very large IOL. Decentration of this IOL is practically not possible. Such a large IOL slits nicely, snugly into the position. Just tightened on two sides. The suture goes into the pocket. The IOL is nicely tucked. Just to show how good a stability is, this is the second video I'm showing from one of my older video. Same technique, practically no change here. Only difference was this eye also required a DSEC. And DSEC typically requires the anterior segment surgeons to maintain a large bubble for a significant period of time once they put in the graft. So once I have done the aniridia SFIOL, my cornea surgeon takes over, scores the descemetes, takes the descemetes out, puts in the lenticule. They are worried to do this in an anaridic eye and as if kick eye, because they are worried the bubble will not be enough to support. The bubble will not be able to maintain the enough pressure to keep the lenticule in place. But this anaridia IOL acts as a great scaffold. You put in the air bubble stays there. It doesn't come out, and the bubble just maintains itself above the IOL, allows for this lenticule to stay in position, just to show how stable this IOL can be for you to do multiple maneuvers later. So that's it from my end. Thank you. Thank you for this opportunity, Arjun, once again.
Thank you for showing those wonderful cases and showing the role of sutured SFIOLs even today. Dr. Vayano has a point to make, I think.
Yeah, amazing surgery. One consideration: how many type of color we have? I mean, two color with the rigid IOL or more.
So in India, we do not get multiple types of colors. We get one brown pigmented. Luckily, most of the Indian eyes, it matches up to. In India, the other iris colors are very rare. Unlike unlike European, where you get different,
Yeah.
iris colors. In India, we basically are either too dark brown or slightly lighter brown. We do not have many more shades there.
Yeah, but my question is because we can use different kind of iris color. But I mean a silicone type iris, artificial iris. so we can fix it at the Carleval IOL by mean Prolin 990 or 100 and fix the complex IOL and iris in the same way that we usually fix the IOL for secondary IOL implant. And is another kind of surgery, but I think that for the aesthetic point of view is better in this way. And we perform a surgery in a tunnel of 4 millimeter. So we have a low astigmatism and a low complication, no? Rate of complication.
That's true, Dr. Vaino. My one small concern, which we have been reading a lot about in publications about secondary glaucoma with artificial iris implants. What is your experience with that? Because we had a lot of publication. We still don't have it in India, but we have been hearing about this secondary glaucoma.
Yeah, this is a very good question because not only glaucoma but endothelial damage over the cornea. In my experience, I perform 5 iris IOL surgery with Carleval IOL, and 2 of these I have a endothelial corneal problems. Glaucoma at this moment, no, I don't have a problem with glaucoma, but endothelial corneals, yeah, I have a problem. So I think that the inflammation of the anterior segment is much more than a suture IOL iris complex. Yeah, I think that is a good point.
Thank you, Dr. Vaino.
So
thank you so much.
Human optics actually does this artificial iris. So in India, at least, if you want to implant that lens, you have to write an exam first and actually get qualified to put that iris. And once you apply for that iris, you have to take the photography of the corresponding eye, and they exactly match in that it's a rubber elastomer which they get that same iris details of the contralateral eye printed onto it, and it comes back after 4 to 6 weeks, and then you implant it. So it is a very elegant, very custom made kind of processes. Again, extremely expensive. That's why we don't have many cases in India. So otherwise, what Vayano sir was alluding to, in fact, we have just filed a patent for an artificial iris with almost similar to this technique which we were trying to tell. We were trying to do it a photochromatic way, so that when you it even gives that dilating and undilating effect, but the coatings are giving us a lot of problem. But anyways, that your idea, we are working on it, sir.
There are 2 kind of artificial iris. One that match only with color, and other with like a draw the same way with other eyes. So it's different cost, and the 2 type of different costs. Yeah.
Those were some very interesting points, and thank you for that wonderful discussion and those wonderful cases again, Ritesh sir. Thank you for being here with us. We'll move on to the last talk of the evening by Dr. Ashray Nayaka. He's going to talk about something which we might see coming up in the future and might change how we perform scleral fixation. I think he'll be the better person to tell us about this other than me giving anything away. Please go ahead and share your screen, Dr. Ashray. The floor is yours.
Thank you, Arjun. Thank you, SG, for providing me this platform to talk on this scleral fixation done right. So far, I'll be talking on two things. What is something known as novel implantable capsular bag, and to implant this, we also needed something more precise. So we modified the Barrett's universal formula to fit our this thing. So when I see the Mount Everest, like the humankind always sees, is it the zenith of everything? So of course, we have seen a lot of refractive surgeries, people getting supervision. So the question which always makes me think and ponder over is, have we reached the pinnacle of cataract surgery, especially the SFIOL surgery? Have we really reached that? So uh, when we are in India, at least we do a lot of a combination of IOLs where we do high number of multifocal IOLs or toric IOLs in our patients. So when there is a compromised capsular support, we are not left with lot of options to actually cater to the high expectation of a cataract surgery in this era of refractive phaco-refractive surgery. So we are only left with all these options which are by and large monofocal in nature. So we thought, why not develop a scaffold to implant a multifocal or a toric lens to fulfill this gap. So that is when we started this journey way back 6 7 years, and this was our version 1, which we had a problem with the anterior wall manufacturing. Then the version 2, we had a problem with rotating, precisely rotating the optics haptic in the slot and rotating it. And in the last 4 years we have been using the third version. And generally there is nothing very superlative about the technique, because we use the Shariat's Gabber technique, which is very reliable, has a lot of clinical evidence, which I don't have to show again. And with this, when there is a bag which has got compromised, why put an IOL which is not been promised? So one size fits all. So once you put the bag, you can put whatever IOL you want, so that you can, once we restore the anatomy of the capsular bag, you can put the IOL you have of your choice, freedom to use any lens, and you don't need any special training if you're well versed with this technique. So this is the three-piece acrylic bag with PVDF haptics. So after this PVDF haptics give you a lot of stability from breakage, and it's like we had one of the cases also had come with a small decentration. We redialed it, and it became absolutely fine even after 1 year. So it was absolutely amazing, which gives stability. So we have been continuing with the PVDF, and we have used a proprietary method to fuse with the bag and with the haptic junction, so that it doesn't disinsert, which happens quite commonly with the PMMA haptics when you over insert the haptic inside the Shariat's tunnel. So this is we have made sure that it has a very tight bond. So this is how you load this. This is how you load this. This is a bag which has a small scaffold underneath, so that the IOL doesn't fall back into the vitreous cavity. Once we center it in the inside the bag, so you just take the cartridge, a B cartridge, which is one of the larger cartridges. So, and just load it with the C loop pointing anteriorly, and then once it is loaded, you use it in your case. So. So this was the first case where patient was 72-year-old male, had come with a blunt trauma with a cricket ball. He was pseudophakic, so at that point of time, I didn't notice any change in the IOL. But there was on B scan, there was some vitreous hemorrhage, and in the antechamber some ifema. So I posted him for vitrectomy for vitreous hemorrhage. So this is a standard pars plana vitrectomy, and the vitreous was not too dense. The vitreous hemorrhage was not too dense. After the anterior vitrectomy, conventional PVD induction, and at the end of the surgery, after the fluid exchange, you can see the IOL has dislocated. So this is something which I had not foreseen, but it dislocated, and I didn't want to leave this like that. So we knew that we had a implantable bag in the inventory. So we carefully made the tunnel, and once this tunnel was slowly, the same IOL was slowly exteriorized, including all its contents of the bag of the sommering. And once it is removed, we use the same lens to load into the bag. Slowly we put it, as I showed you in the previous video, where how we load into the bag. Once it is loaded, we put it back, and after marking at 180 degrees at 1.5 to 2 from the limbus, the sclerotomies were made, and we fixed it at on the both the sides. This is how we fixed it, and tucked it into the Shariat's tunnel, and sutured the tunnel. So this was at the end of the surgery, and this is how it showed at the end of 3 months. You can see the on the anterior segment OCT, you can actually see this small platform on which the whole IOL sits, and it is quite centered and stable. And this is another case where patient had a nucleus drop with CTR. Patient was promised with a multifocal IOL. So, but since we use this technique called IOL drop technique, so we don't mess around with handshake and all those things. We put it directly into the vitreous cavity, and under direct visualization, we exteriorize from the vitreous cavity itself. So it is operationally very easy, saves a lot of time, and then once it is exteriorized, you just tuck it in, and this is the IOL, which is well centered, which is inside the bag which we have implanted. So basically, we generally get a good centration, and once you know the what sclerotomy you are doing at what distance from the limbus, you know that ELP is very much predictable. So you can see this is the multifocal IOL. You can see the refraction. Patient has 6/6 vision with zero spherical error, and near vision also doesn't need any big correction. So everything is zero. So this is almost like a refractive doppelganger, which we could achieve with using this technique. So absolute centration, and even an anterior segment OCT, no tilt or anything. So this is what we have achieved with this thing, and to even demonstrate how the on the anterior segment OCT of the sclera, you can see the how well it is tucked in the sclera, and it is quite stable with its positioning. So this technique, we actually did a small study, and with a 66 eyes with a mean age of 57 years, male and female, predominantly male patients, and we could see that we had all these indications: aphakia, dislocated IOL, subluxated IOL, and ectopia lentis, and we had good outcomes, almost near emetropic outcomes with since we don't make a huge tunnel with sclera, the uncorrected visual acuity always stays better, and the cylindrical value was minimal, and as we have evolved with the surgery, it has become even better. So I will these are our post-op cases with the bag with the IOLs, and with this anterior segment OCT, we can actually demonstrate how well the IOL sits very well on the scaffold which is being provided by the implantable bag. So ours is not the like though we have been doing for the last 6 7 years, but the West has been not quite. It is not only one person in the whole world gets the idea. A lot of other people also get the idea. But Santoro Noguchi from Japan actually won a prize for his bag, which actually he implants it in the intact capsular bag. So the for his main problem was IOL exchange at a later date. So basically, you can only implant a mono bag in an intact capsule. So again, this is not the only innovation. This year, Frankel Brody has also published in 2026 the prosthetic capsular bag. Again, there are flanges. This is fixed at 3 points, and you can see the slot. It can only put the C loop haptics of the monofocal, and here they have used MA60 IOLs. Again, this is more for more to manage their complications with the monofocal IOL. They have not ventured into a multifocal IOL. And this is where we score over these innovations, because the prosthetic capsular bag or the Santoro Noguchi's artificial bag can only put the C-loop IOLs, because that is the only haptic slot they have. If the IOLs are of a different shape, or something like this or like this, then they can't be used in their surgeries. Unlike in our cases, we can use any of the IOLs because we don't have to conform to the haptic design. It will just stay outside the bag, suspended in the just behind the iris. So to put a multifocal IOL, we need to even be very precise with doing our biometry, because ELP prediction in the standard Barrett's formula takes all these things: axial length, K, ACD, lens thickness, Y to Y diameter. All these things are taken into consideration, and by and large is dependent on the axial length. But SFIOL sits wherever the haptics are anchored. So these positions are symmetrically different, and this can give you that hyperopic shift, which is very difficult to handle if you are managing a patient with a multifocal IOL. So that is where this ELP gives you an opportunity to produce, to actually predict the ELP in our cases. So we did a small study of 50 eyes. We used this technique of IOL drop technique, and fixed at 1.5 mm from the limbus, and actually measured the ELPs after the surgery. And this is because prediction of ELP in Barrett's 2 is very theoretical, and takes an average and has multiple factors. So that is why we wanted to modify this and use it so that we have a precise point or precise knowledge on which power to implant. So this is a standard technique which we use. So you have to even take consideration of the haptic angulation and the Barrett's lens factor, which is very specific to these things. So once you have done all these things, we actually measured all these sag depth, theoretical ELP, which is there in the Barrett's, and measured our ELP in our cases to be in 4.75 to 4.78. So this ELP is not stable from the day one. So at 6 weeks, it can be lesser, that is 4.7, and by 6 months it can be slightly more. And on average, you can see it can have a range from 4.5 to 5.5 mm. So this is what makes it bit difficult to use the right power. So we actually measured with our technique, we actually measured the tilt also with a specialized formula, and we could see most of it, 82% of it fell within 2 degrees, which are not a big confounder for any of these lenses. So this is the formula which we have adjusted. So this is a standard Barrett's universal formula which uses a theoretically predicted ELP, but since we have averaged out and measured the sclerotomy and what is a deep sclerotomy, what is the effective lens position, we have put that value in this modified Barrett's SFIOL formula, and actually studied that if there is a 0.35 ELP shift, then there is a zero point 0.5 adapter shift per 0.35, and this is quite in agreement with the geometrical model. And with this, we have come to this normogram that if you take the Barrett's SFIOL2 formula, which is comes across IOL master or anything, you take at 1.5 add 1, or if you 0.75, then you add a 0.5 adapter. But if you are putting at 2 then you don't have to change anything. You directly implant whatever lens power which has been given in the calculation sheet of the IOL master and put it at 2 So this gives you unmatched and uncompromised the way to manage your patients even with whatever demand, and does not need any additional training, and you can use any IOL. And for pediatric patients, you can put the IOL which is there in Marfan syndrome and all for that age, and at a later date you can go back and easily do an IOL exchange, which Santoro Noguchi wanted to do that. So it solves both the purposes of my elegant inventors, Dr. Frank Brody and Santoro Noguchi. So finally, we have been using, and a few of my partner people in other institutes have also used it and found it very useful in their clinical practice. So thank you for your kind attention, and be happy to take any questions.
I think that was an amazing presentation, and you addressed two very relevant concepts, which the anterior segment surgeon in a retina surgeon always thinks about while doing scleral fixation, which is how to give multifocality or correct toricity, and how to get that effective lens power or the correct lens power with that formula. Very nicely shown surgeries. I think Dr. Amog had one similar question, which you addressed in the later part of your presentation. And I'd just like to open this up if any of the panelists or audience have a question before we close.
Dr. Ashley, a very nice talk. I
Hi,
would
Atul
just
sir.
like, just like to ask one question. What is the main advantage of this capsular black implantation over simple glue dial technique?
Sir, our technique wise, it is all the same. We are just doing the same Sharad Gaber's technique, which what we were taught by Amar Agarwal about the glue dial. In fundamentally, the principles are the same. If you want to put a multifocal IOL or a toric IOL, which sometimes you would have promised, and then you don't want to go back on your words. This is something which we have refined over almost so many surgeries, and come to a conclusion that it works well in real life scenarios. So basically, the advantage is you can put the IOL which was promised preoperatively to the patient. If it's panoptics, you can put panoptics. If it is ODC, VVT, whatever, you can put it.
So that means you want to give 6/6 and 6 vision even after the glue dial, even after the secondary eye implantation without any specs.
That is the goal, sir. That is what
Okay.
the pursuit is. So the
But in your study you have shown that the this cylinder power was almost 2 plus minus 1.25. So even after doing all this, the factors are the confounding factors are still the same. That means the sclerotomy should be at the exactly same point.
Correct.
That means if you are doing one side 1.5, the other side should be also 1.5.
Absolutely.
The haptics should be exactly same exteriorized. In real world scenario, what I feel, it is not possible. It is not possible to do exactly same measurement on the both side. Have you ever seen that if you are doing 1.5 millimeter from on one side, some because of some other reason, other side 1.6 or 1.7 is also there, and you are not, and most of the time even I have done many cases, I am not able to do the exact same size of sclerotomy. One side the sclerotomy is little more, the other side the sclerotomy is little less, so the exteriorization of the haptic is also depends upon that situation.
Sir, a surgery is a precise endeavor, sir. We have to measure. There is no compromise in that. If we are somehow unable to measure, then this is not the technique for us. So this is a technique which like if you want to put a monofocal, all the other speakers have all very elegantly shown put a monofocal lens and leave it. There are people, at least in our practice, who need it. So we have, in fact, this whole idea came because I was doing multifocal SFIOLs. So instead of then the multifocal SFIOLs went out of vogue with their three-piece designs. That is when we came up with this. Yes, you have to be very precise in your markings, and if you are not able to deliver that, then it's not the technique we should be following.
Thank you. But really very good idea. Very good idea. Maybe in the future you will come up with the exactly the same everything, both the same, some marking on the IOL or some marking on the back, that everything should be same on both the sides.
You have to mark it, sir. Otherwise, then even normal SFL also you'll have a lot of refractive surprises. You have to mark it.
Yeah.
So, thank you so much for all these wonderful talks. The discussions were really engaging, so much so that we've almost exceeded by an hour. And I'm glad that everyone could join in. And for those of you who stayed on for the extra 50 minutes that we exceeded time, thank you so much. Thank you, Dr. Vayano, for joining in. Thank you, Dr. Mandelkorn. Thank you, Ritesh sir. Thank you, Dr. Ashray, for that amazing talk. Thank you, Dr. Mansoor. And thank you everyone else who stayed on and all the panelists. And I think this is one topic which everyone enjoys, and as retina surgeons this is also a very gratifying surgery for us because we get a pretty instant visual outcome. That's not something which we are really used to as retina surgeons, where we always wait for the gas bubble to go away or the oil to be removed before giving a final outcome. But this is one of those surgeries which we all enjoy, and it was wonderful to see all these amazing surgeons give all their different techniques. Thank you so much, and thank you everyone for being here. If anyone has anything else to add before we close, we can just take that up. Otherwise, we can close for today. Thank you so much, everyone.
Thank you, Arjun.
See you.
Wonderfully conducted.
Thank you, Arjun, for the wonderful class.
Thank you. We'll close today. Thank you everyone for coming.
Abdul sir, bye.
Thank you.
Bye.
Bye, Ashray.
Thank you.
Gazab
Thank you,
idea.
Arjun.
Gazab idea. Ashray. Superb. Superb. Heads off.
Bye. Good night.
Thank you, sir. Thank you.
Bye. Good night.